Okay, we're going to review the integumentary system. Now, this is just a few things that are um, pretty much so in your NCLEX prep book. First thing I want to talk about is Candida albicans, um, also known as a fungal infection or a yeast infection. It's when it's in the mouth, it's also called thrush. So any time you have an environment with moisture, if the patient's immunosuppressed, like if they have chemo, or if they've been on long-term antibiotic therapy, diabetes, or obese, they're at risk of developing a yeast infection. This can be, again, in the mouth. You see the white on the tongue there. That's thrush. It could be a yeast infection in the for the vagina. It could be an infection in the skin. A lot of times you'll see in a hospital environment skin folds, people that are very, well, it doesn't even have to be obese, but any skin folds, if they don't keep it clean and dry, it can develop this kind of a nasty, you see like a white yeast, and it's very stinky. Excuse me. So you can treat this like for the mouth. You can use like a nystatin liquid that they can swish with. Even the nystatin, there's like a nystatin powder that we put in folds, like the folds of the skin, to dry them out. Also, fluconazole, that's one of the medications that's used for a vaginal yeast infection. Yeast, it's normal. It's a normal occurring. We all have it. We all have it. But the difference is it can have an overgrowth, typically when you're immunocompromised. So as long as you're healthy, you've got this Candida albicans all throughout your body, and it doesn't bother you at all. Herpes zoster. This is shingles. Shingles is basically reactivation of the virus that people that had chickenpox. So if you had chickenpox as a child, then as you get older, you could have a reactivation of that particular virus, but it comes back as shingles. It runs along nerves, so often you can see it there on the side, like that picture on the side of the body. My dad got it along his nerve right here, down his face. I know someone else that actually got it in their eye, which was horrible. So again, it is a virus. We can't do a whole lot about viruses. We can give antivirals, but all they do is help reduce the amount of virus in your system, but you're still going to have to just ride it out. Biggest thing we do is we treat the symptoms. We help make the patient comfortable, which could be giving them something for nerve pain, because it does ride along the nerve. So like gabapentin is often used. Fever, they just don't feel well. It's painful. It is very contagious. So you need to isolate the patient. MRSA. A lot of us are very familiar with MRSA. This is contact we have in the hospital. People that have MRSA, they are on contact precautions. So MRSA can be in the wounds. A lot of people have MRSA in the nares. They say all nurses in the hospital have MRSA in the nares. I don't know if that's true or not. I don't know if I've been tested for it, at least not since I had surgery, which was a long time ago. So it's also contagious, and it's contagious by direct contact. That's why we gown up before we go into somebody with a MRSA. We gown up and protect ourselves. It's confirmed by doing a culture and sensitivity of the wound. Basically, it's a swab the wound and send it off. And MRSA can spread to other parts of the body. It can get in your blood. It can cause sepsis. Basically, it can even cause death. Antibiotic therapy is used. Typically, vancomycin is the antibiotic of choice for MRSA. Skin cancer. We got some lovely pictures here of skin cancer. We've got the first one, the the gentleman, the side of his face. It's a squamous cell carcinoma. And then the right top is a basal cell carcinoma. And the right bottom is a melanoma. Which one do you think is the most deadly? Because, I mean, certainly know which one's the ugliest, but that's not the most deadly. The most deadly is the right bottom, is the melanoma. Basically, it's a malignant lesion that may or may not metastasize. You got your basal cell, which is from the basal cells in the epidermis, and it's rare for that to metastasize. A squamous cell is a tumor of the epidermal keratinocytes. It can infiltrate surrounding structures and metastasize to the lymph nodes. Melanoma, like I said, that's the big one. That one can occur any place on the body, and it's highly metastatic to the brain, lungs, bone, and liver. That one will kill you. Number one cause for this is overexposure to the sun. Got to wear your sunscreen. There is a genetic predisposition. Could even be caused by radiation. People that are most at risk are the light skin, fair skin, fair haired. If you have light skin and red hair, you better just cover up, stay out of the sun. Typically older than 60 if you have an outdoor occupation. The way it's diagnosed is a skin biopsy. They basically just do a biopsy of that, send it off to check. And then it can be cryosurgery, that's basically freezing it, or it can actually be cut out. But you can also have some non-surgical methods, like drug therapy or radiation. Okay, now we have psoriasis. You can see these scales. They're basically called scales, plaque scales on the it looks like arm, on the elbows. This, you can have remissions and exacerbations. A lot of times this is an autoimmune reaction. It can be from stress or trauma. Could even be climate. Some people eat too much wheat. They can have psoriasis, a breakout of psoriasis. I was trying to think, is that psoriatic? I don't know. We treat it, there's no cure for this. But we do treat it with corticosteroids and basically topical therapies. There are some medications that you can take, because especially if it's an autoimmune response, that like Humulin, that will reduce your immune system, so it'll suppress your immune system, so it will cause you from having these autoimmune breakouts. But there's an awful lot of other considerations with that, because now you've suppressed your immune system, so you're susceptible to other infections. You can do ultraviolet light therapy, systemic therapy. That's basically taking an oral medication. All right, we're on to pressure injuries. This is really big. This is something that anytime you're caring for a patient, you need to be aware of their pressure points, and you need to make sure that that's where we float the heels. We put the pillows up under their ankles to float their heels to prevent that, or we constantly change them. If they're bed bound, we move them and change their position every 2 hours and prop them up with pillows to help prevent this pressure injury. Or we try not to pull them in the bed. Sometimes we can call it shearing injuries. But it's compression of the skin and the soft tissue between bony prominence. Could be pressure from friction or shearing injury. Prolonged bed rest, immobility, incontinence. That was the thing with, they used to put a catheter in just about everybody at the hospital, catheterize them. It was easier for the nurses. And it also helped prevent people from getting pressure injuries, because they weren't all wet and with their pee, so it didn't, their skin was protected. However, the number one hospital-acquired infection is a CAUTI, which is the catheter-acquired urinary tract infection. and any hospital-acquired infection, insurance will not pay for. The hospital has to eat the charges. So the hospital says, yeah, we're only going to put a catheter in if we absolutely have to. So now we have more people that are just laying on the chucks and they're laying in their own urine. So now we have skin integrity issues. Again, somebody comes into the hospital and gets a pressure ulcer while they're in the hospital, hospital acquired. Again, insurance doesn't pay for it. But I guess the hospitals feel like we have more control over that by doing the proper, taking care of the patient properly by repositioning and making sure that they stay dry. It's also inadequate nutrition or hydration. People that have poor nutrition, they're very susceptible to this. And altered mental status, again, because they're basically lying in their own urine or whatever and they're unable to communicate this. Prevention, an ounce of prevention is worth a pound of cure, right? So we want to look at their risk scale. The risk scale, there's like a Braden scale. Braden scale, you go through and it's like a series of questions and it gives a numerical value to determine the risk. So it's different things like, are they mobile? Are they able to turn themselves? Are they, their nutrition level? Anyway, if it's anything, if that number is 18 or less, that's at a risk. Gets higher, I think where I worked before, it was like if it became 13 or lower, that sent out an automatic notice to the wound care people. So they would come in and assess, and that person may need like a special mattress. Aggressive intervention of prevention. That's interventions. Let's see. A lot of times we put a lot of different paddings or extra padding to help protect their bony prominences. This is what a stage 1 pressure ulcer looks like. Skin is intact, but it's red and it doesn't blanch. If you push it in, it doesn't blanch. So that person right there would need that Mepilex, like that heart-shaped pad that goes on there to help protect that bony prominence right there. That bone, you can see that bony prominence. That's got to be very painful. Stage 2, the skin is not intact. You have partial thickness skin loss, and you can see it, but it kind of looks like an abrasion or a blister, but its skin's not intact, but it's not too terribly bad at this point. You definitely want to keep that covered and protected so it doesn't get worse. Stage 3, now this is when it starts getting nasty. That's when you have a full thickness skin loss. You start seeing the underlying fascia and the tissue, and it starts to look damaged, and it can even be necrotic. You don't see any bone, tendons, or muscles, but you will see all the other underlying tissue. And then stage 4, that's the worst. That's when you can see the muscle or tendons or even bone. Often you'll have some tunneling, slough, and eschar. That's where you'll have to really have a wound care nurse, or sometimes in some situations that would be you. So usually the physician will give you orders of like what you may need to do. You may have to do like a packet, do like a wet to dry packing, or different medications like that Medi honey put in there. So when it gets to that point, you definitely need to have I would imagine a wound care specialist take care of that. So that's it on skin. If you have any questions, you know how to get me. Send me an email, reach out to me.